Good afternoon, everyone, and welcome to Medical Grand Rounds. Before we get started, I'd like to remind everyone to please enter your questions in the chat at the end of the presentation. As well, I'd like to remind everyone to please fill in a very brief survey that will be sent to you right after the presentation. This will let us know that you were present today. And finally, before we get started, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. It's a great pleasure today to have medical oncology hosting the Medical Grand Rounds. And I would like to ask Dr. Nathaniel Buganim to please present our speaker, Dr. Jamil Asselah. Nathaniel, the floor is yours. Thank you for being here. Thanks to both of you for being here.
Thank you, Nadia. So, without any wastage of time, because I know Dr. Asselah has a lot to talk about, Dr. Asselah is part of the team since 2011. Previously has done his training at Institut Curie in France, where he did phase 1 and phase 2 trials, and then came to Sherbrooke, where he built pretty much the whole medical oncology department in Sherbrooke. Before it was really a heme-onc department, and then was recruited at McGill in 2011 to join the breast team and colorectal team. More recently, he's been the president of the McPeak-Sirois Consortium for Breast Cancer, which is a single guichet for all clinical trials for breast cancer. And even more recently, he's been putting McGill University on the international map with designing and conducting first trials with antibody-drug conjugates for patients with breast cancer, especially triple-negative breast cancer. So without any ado, I'll let the floor to Dr. Asselah.
Thank you, Nathaniel. Thank you, Nadia. I'm very pleased to be here. So I will try to make it simple, a very complex thing, but I hope you will have a lot of questions after the lecture. Thank you very much again. So I am a member of this big study, Global Steering Committee. So this is my only conflict of interest that we are running now at the MUHC. So I sent some objectives. So I will explain to you what is antibody-drug conjugate. I will show you some progress in clinical trials. I will show you also our leadership at the MUHC for breast cancer trials. And I will discuss the global implication. And I will try to tell you what will be the future. This is the agenda. I need to start with an overview about the breast cancer. What is the breast cancer and the limitation of treatment, and the challenge with this subgroup of cancer, which is a triple negative. And I will explain to you the antibody-drug conjugates and how it works. It's a very old concept, start like 100 years ago with the magic bullet to kill cancer. And I will focus on breast cancer, and I will tell you the story of our clinical trials. And we will discuss the efficacy, the patient outcome, the safety, and the future. So let's talk a little bit about the breast cancer. What is breast cancer? What is very important is to understand two kinds of cancer. The in situ cancer, which is a local disease, we don't stress, we go for surgery, sometimes radiation, sometimes hormone therapy, and usually it's never occurred. But the problem is when it's crossed the membrane basal and it's come back as an invasive cancer. An invasive cancer, we can still go for surgery, but there's a risk of metastasis. And when there's the risk of metastasis, there's a risk of death. But don't imagine that one kind only of breast cancer. There's many breast cancer, and we can have very good breast cancer and very horrible one. For example, the adenoid cystic carcinoma that you see on this histology slide are very good. Usually you do surgery, and after that you don't do anything. For the rest, you have more aggressive, like pleomorphic cancer, lobular, that is more aggressive, and we need surgery, radiation, chemotherapy, target treatment. We start to do a little bit of molecular around 2020 when we start to understand the different subtypes of breast cancer, from the basal-like, which usually is a triple-negative breast cancer, to the luminal breast cancer, which usually are ER-positive breast cancer. And you see that the prognostic is totally different between triple-negative, which unfortunately, when you have stage 4, less than 10% of people will live more than 5 years, and stage 1, you are cured. But when you have ER-positive breast cancer or HER2-positive with all the treatment, even with the stage 4, you can live. Recently, we have this molecular classification, but we were able to, with the immunochemistry, meaning easy technology, easy staining, we are able to do the same molecular classification just by staining. So ER negative, ER positive, low proliferation versus high proliferation, and HER2 staining. So it's very easy as a daily practice to use this classification. If you want to understand a little bit, you just have to understand that. So breast cancer subtype, the ER positive, which is the majority, the triple negative is the minority, but they are the worst, 10 to 15%, but the worst, and a HER2 positive breast cancer. And recently, and because of clinical trial, because of this ADC, we were able to subgroup a HER2 low, because in the past, there was nothing for this subpopulation of cancer, and we've done a clinical trial with an ADC, and we had a success story, and that's why we changed the classification. If you take the ER-positive patient with the low proliferation, what we call the luminal A, they have a very good outcome and are the best prognosis. If you take the triple negative, you don't have any target, they're the worst prognosis. So you understand that there's some limitation of the treatment for the triple negative. For the old cancer, when it's an early stage, we can do surgery, radiation, and for TNBC triple negative, and for ER positive and HER2 positive, we have targeted treatment. Since 1970, we started doing chemotherapy. Before that, there was nothing. There was surgery, there was some endocrine therapy, but the chemotherapy started recently, 1970, and after that, more development, 1980 with anthracycline, 1990 with taxane, and capecitabine in 2000, and now more and more with the new ADC. We have so many, and few are on the market. I will give you more insight about this new ADC, and we focus more and more on real-world data and also on the quality of life of the patient. So for ER positive and HER2 positive breast cancer, the prognostic has improved due to the introduction of target therapy, anti-HER2 and the CD6 inhibitors and other. Unfortunately, for the triple negative, except the immunotherapy for a subgroup of patients, we didn't done so much. What we do now, if we have a patient with ER positive, we do surgery and we propose anti-hormone and CD6 inhibitors, sometimes chemotherapy. For the HER2, we always give chemo plus anti-HER2. And for the TNBC, depends on the BRCA mutation, but after surgery, we give chemo, and when advanced stage is advanced, if some CPS is more than 10, we can give some immunotherapy. But again, this subgroup is not so good. That's why I will focus today on this subgroup. The prognostic of triple negative breast cancer, if you have stage 1, early stage, you do very well. Everybody, quasi everybody are cured. Stage 2, stage 3, it's 60%. So you start to be like not so good. And in stage 4, as I told you in the introduction, less than 10% of people live after 5 years. Terrible. So the challenge in treating TNBC, if we start to understand TNBC, it's not only one disease, so it's a lot of subgroup, and we start to look after the pathways of different subgroups, but nothing is working very, very well, even if we try to block one pathway, except the BRCA1 and 2. What we learned in the past is if we give chemotherapy before surgery in at least 2 subgroups, the triple negative breast cancer and the HER2, meaning before that we do surgery, and after that we do chemotherapy. But since 10 years, we learned that if we give chemotherapy before surgery, and if we reach a pathology complete response, meaning the surgeon sent the specimen of the surgery to the pathologist, and the pathologists are not able to find any invasive disease, we know that this patient do very well after that. So it's a very easy endpoint to measure, and after that, in our clinic, when we meet the patient, we know that the patient will do well. So we start to do more and more neoadjuvant treatment before surgery to have a prognostic and to tailor the treatment to individual patient. So in stage 4 disease, unfortunately, we don't have anything except some immunotherapy for a small subgroup that is CPS more than 10. We give chemo plus immuno, and even without, it's not the best. And after that, in second line, we don't have so many treatment. Recently, we have again an ADC which improve overall survival in second line. So what is the antibody-drug conjugate? What are these medication? So this novel approach is based on a very old concept, which we want to bring with the antibody, the drug inside the cancer cell. So antibody-drug conjugates represent a dynamic and evolving category of anti-cancer agents. They consist of monoclonal antibodies linked to a biological active drug, allowing to the targeted delivery of cytotoxic compound to the tumor site. So we have less side effects and more efficiency. So you can see the chemotherapy on the right, linked to the antibody and the cells, the cancer cells. So monoclonal antibodies, MIBS, monoclonal are proteins designed to target specific protein on the surface of cancer cells. Thus, proteins known as antigen are often overexpressed on cancer cells and play a role in their growth or survival. Binding to cancer cells, the monoclonal antibody in ADC are engineering to recognize and drive specifically to the surface of antigen on cancer cell, and it's highly selective, so less side effects. And after that, you have the internalization and the release of the cytotoxic payload. The payload is the chemotherapy agent, which usually, if you give it as an intravenous infusion, is very toxic. And we can kill the cancer cell and also sometimes the cancer cell around some of the tumors that is not expressing the antigen. Here, how it's work. You have the monoclonal antibody, the chemotherapy, and it will target the antigen, and it will go on endocytose inside the cancer cell, and after that, it will release, and it will kill the cancer cells, and the cell will. So this is a very nice, it works. I will show you the data, but it's a very nice concept. And what we call the bystander effect in the context of antibody-drug conjugate, because you will hear a lot of bystander effect, is referred to the ability of this therapeutic agent to not only kill the targeted cancer cell, but also affect nerve-beat cancer cell that may not have been directly targeted by the ADC. In other words, the cytotoxic payload released by the ADC can have an impact of the cell around the cancer cell, which is also cancer, but also some toxicity due to the molecule. And in breast cancer, it was really like 20 years ago, the first ADC, the trastuzumab emtansine. And after that, there was the trastuzumab deruxtecan, the SG, the DATO, but there were more and more drugs. But I will just focus on this fourth. And after that, of course, there is a question. I can go for more details if you want. So there's a lot of ongoing study in neoadjuvant and adjuvant setting now. So trastuzumab emtansine is trastuzumab with emtansine chemotherapy was the first ADC approved in breast cancer in 2013. TDM1 is an ADC where the antibody trastuzumab is joined to the microtubule inhibitors, the emtansine. And again, this chemotherapy, if you receive it like infusionally directly, it's so toxic, it's very, very toxic. But attached to the monoclonal antibody is the toxicity. It's a very safe drug and very efficient drug. So half a decade later, two more ADC have received FDA approval. It was the trastuzumab deruxtecan and the sacituzumab govitecan. Deruxtecan is a drug compound derivative of hexatecan mesylate, a topoisomerase 1 inhibitor, which actively close to 10 times that the very well-known irinotecan, that we are the metabolic of the irinotecan called SN38, which is the active metabolite of this drug. So it's a very well-known drug that we are using, for example, in colon cancer and gastric cancer. TDC is approved in both second-line treatment and for patients who have received prior treatment with TDM1 in HER2-positive breast cancer. But as I told you in the beginning, it's also approved in HER2-low, meaning the HER2 breast cancer in the past, it was called HER2-positive and HER2-negative. And now, because of this drug, we have a new classification with HER2-low, 1+, 2+, that are not amplification with the fish. So SG is targeting the TROP2 protein. So it's another kind of protein, but the TROP2, it's expressed in all TNBC in breast cancer. So we don't need to test the TROP2 expression to give the treatment. And dato-deruxtecan is the last one that is not approved for now, but we are doing a lot of clinical trials with this drug. And it's also combined with the same chemotherapy, which is the topoisomerase 1, the deruxtecan. So where are we in this daily life with the ADC, and why are we leading the clinical trials? If you see all the treatment, we always focus on what to do in neoadjuvant setting, what to do in adjuvant, what is the guidelines for the first line, what is the guideline for second line. So we always focus on clinical trial. We always want our patient clinical trial because it's a standard of care and the data are good and the drug that's innovative good. If you see in neoadjuvant setting, we have Destiny 11 trial, so ADC in neoadjuvant for HER2 positive, and we are leading in terms of number of patients, all the America. And also in triple negative, we had two trials, very nice trial, Tropion-03 and Tropion-04. So Tropion-03, I told you about the neoadjuvant treatment, so we give chemotherapy, and in case of after surgery, we still have residual disease, we have a trial with the dato in ADC that we give after neoadjuvant chemo, and we expect to improve the outcome because we don't want this patient recur. Because again, stage 4 TNBC, it's very bad. So, and we were the first center in the world to have the first patient. So the first patient in the world was at the MUHC. And the Tropion-04 was another trial, neoadjuvant. So we are using dato in neoadjuvant instead of the classic chemotherapy. First line metastatic, again, anti-HER2, the trastuzumab deruxtecan, we are leading North America trial. So we are not bad. And in first line metastatic, we have other trial with also dato. I will not focus on metastatic trials, but I will go over the neoadjuvant trial. Why? You understand that it's a big unmet need because of the life expectancy, but also the chemotherapy that is standard of care for now, for 2024, is a chemotherapy came from a trial called KEYNOTE-222 using chemotherapy plus immunotherapy, but many patients, 28%, has discontinued the therapy because of the side effects. And 37% of this patient has residual disease at the time of surgery, meaning that this patient, the 37%, probably will have a recurrence and because of the stage 4 will die at limit. So there's a lot of unmet need to improve the outcome, to improve the pathologic complete response, but also we want them to live better on chemotherapy. We don't want them to stop the treatment. We want them to have normal life, to focus on the family, to focus on the job, to focus on the life. We want patients to live normally during the treatment. So we had to have this new ADC that target TROP2, and we were looking for trial. And in 2018, December, they designed a very complex study to put this ADC because it was not the population, the oncologist that was thinking about, oh, yes, it will work. So it was a very complex design with 6 arms called Begonia. So we look after the study and we decide to open, but not all part of the study. We want to focus on the dato, the ADC plus immunotherapy, because for us, it was the best strategy. So we opened it when we were like arm 6, which is the dato, the ADC against TROP2 plus immunotherapy. And in 2020, we asked all the patients to come. We opened our network. We said, oh yeah, we have a trial, refer a patient to us. So many patients came and we started this trial with dato, potamab, deruxtecan, ADC against TROP2 again, plus immunotherapy, durvalumab in first line for patients never received treatment, unresectable or metastatic. And we present the data at Miami in 2023, so close to 1 year ago. And you see this response rate in this wonderful and this prolongation of the response. And it was a number that we never saw, when they asked me to explain stuff of the data. I said, well, this patient is 25 years old. Yes, I'm following her. Her first name is Natalie. This is the patient. So I knew many of these patients that I was showing. So it was not only numbers. It was, no, she's doing very well. She have a family. So it was crazy for me to see this stage 4 living well and having this kind of response. And a few months ago at the ESMO, my colleagues present another update with 79% of response with this combination and 30.8 months of PFS. The trial is ongoing, but the majority of the patients are still living with a very good response, and some of them have a complete response. So it's the first time that we saw that. So in our brain, we can't leave this data like that. We need to go ahead in neoadjuvant. So the FDA was really there was not open to move so fast to the neoadjuvant setting. But when they saw the data, they approved it. And again, here at the MUHC and the McGill, the ethics committee in Quebec was saying, you can't do a trial without chemotherapy. I told them, guys, it's a new chemotherapy. It's a chemotherapy, and look at this data. So I had to show many times the data, and finally they approved the trial, and the dream turned into reality with the implementation of the Tropion-04 study at McGill, MUHC, and at the end, we opened 17 centers in Canada. And we were like in the steering committee, be able, because usually the problem with the clinical trial is we always focus on the science, but we are not close to the patient. When they call TNBC, triple negative breast cancer, if you want to run a trial, by the book, you have to have estrogen less than 1%, progesterone less than 1%. But we know that patients who have 9% of estrogen, 8% of progesterone, they still be like, the outcome will be like triple negative. So we advocate that, and at the end, everybody agreed that we will be open to also hormonal receptor low. And the cutoff was 10%. So it was very nice because we focus on patient, and we also done a small group. If the patient is BRCA mutated, she will be able to receive PARP inhibitors with immunotherapy. So, and the design is this, you in a phase 3 design, you always have to have the classic arm, the control arm with Pembro and AC and Taxol Carbo, and the experimental arm with this ADC targeting TROP2 and immunotherapy again. So we go for neoadjuvant for stage 2 and 3. And after that, for the surgery, the endpoint is the pathology complete response, but also there's a lot of questionnaire about quality of life and EFS. And they asked you with the statistic 1,728 patients all over the world to participate. So many countries are starting to open. Australia, Belgium, Brazil, Bulgaria, Canada, China, France, Germany. I will not go, but many countries. And interestingly, if you see here the data of last week, you see that Canada is #1 in the world, and Taiwan is following us. And we have 17 sites in Canada. And if you see, the US will have more than 150 sites. So it's a big trial, and we are like open now. So it's good to be the first, but for sure when US and China will run completely, we are not expecting to be the first on number of patients because of our population, but at least we are leading this trial, so we know the side effects, and the first patient in the world going on surgery will be at the MUHC. Let's talk about the efficacy. You understand a little bit that it's a trial ongoing, so we don't have many data except the data that I show you for the Begonia study, and yes, and my patient that I'm seeing in the clinic, and my colleagues oncologists, they see also the patient. The safety is because the TROP2 is expressed also in other sites, like in the mouth. So the main side effects with the DATO will be the mucositis, but it's also the hematogenic is half-half, but the severe one are not so bad. But you have to premedicate the patient before starting the treatment. But the worst is the mucositis. We had to stop the advanced trial, not this early trial, but the advanced trial with begonia because of mucositis. The mouth is horrible, patient can't eat, can't do anything. So what is important is to make sure that the mouth is clean before starting the trial. I sent all my patient to the dentist. There's a precaution, there's prophylaxis, mouthwash. So there's a lot to do. And if you do that, it's a lot. It's 3-4 times a day mouthwash, but at least patients do very well and they have less issues. This is in red, what I told you, brushing teeth twice a day, daily flossing, and sending to the dentist before starting the treatment. But we do that anyway for all the chemotherapy regimen. But for the dato, we have to focus on the mouth. And because the dato is with the immunotherapy part, so we are like you and you guys, everyone in the room, because we are using immunotherapy since many years, we know how to deal with all the reaction, but it's pretty rare to have immunotherapy toxicity. But we have experience, how to deal with. And I will not show you the guidelines, but you know how to use steroids in this kind of, if you have side effects. But the patient are very close monitoring. We do very close monitoring because of clinical trials. And you know that in the beginning, in immunotherapy, you have the rash more often, and after that, the diarrhea, and after that, with the months, you do. But now, because we do only 6 months of treatment, but immunotherapy will go for 1 year, we will have the acute side effects, and after that, we have to be careful when we give immunotherapy only. So efficacy. So now, we the first patient in the world since November. I can tell you, it's easy because they are locally advanced. So for me, measuring the tumors in each 3 weeks, I see, and the patient also feel that it's shrinking between 1 and second visit. So even after the first treatment, patient told me the mass was shrinking, and I saw that during my physical exam. So they do very well. So we focus on the mouth. The mouth is the main problem again, but they have very good quality of life, and half of my patients continue to work. So the dream is, if we find the same response, but I'm expecting to find more response because of this begonia study publication, if you increase to 85% of pathology complete response, and if they live normally during the treatment, what can we expect more? This is our expectation and our dream as an oncologist, to have patient on treatment and living normally. So what does it mean, all the trials and focusing on patient and needing everything that we do? For sure, if we are able to improve the response rate, meaning that we will improve the cure with this TNBC, they will have less recurrence, and this ADC will become a standard of care in my expectation is 2026, at least in neoadjuvant setting, because of the number of patients and number of events that we have to calculate. Where we are going, I'm pretty sure when I see all the trial and how work the ADC, and every 6 months, it's like the iPhone, or Samsung, like every year we have new technology, less toxicity, more efficacy. So it's a revolution. It's a revolution. It's true that there's the vaccination are coming, there's many drugs that are coming also, but the ADC are here and they will stay here, and it's adding another important new class of systemic therapy, and you have to know the ADC. The mechanism of action is very good, very great to understand and to know. There's so many ADC ongoing, and in breast cancer, for example, we have an amazing phase 1 ongoing now for patients who failed many treatments, estrogen positive, and it's again what we call one of the proteins that we call B7H4. And patients who don't in the past didn't have any option, now if they are still in good shape, candidate for clinical trial, they are able to go on this ADC. Just to tell you that we have so many trials ongoing and coming with ADC. This is something that will change the outcome of our patient. Let's start it. The implication, it's true. So for the past 3 years, so now it's 3 years that the MUHC have been the leading institution in breast cancer study in Canada in terms of patient enrollment. And we are the global leaders in the Tropion-04 trials. If you are doctors, if you are an oncologist, you have to ask your patient to go on trials. This is the best treatment. And if you focus, and I don't know, there's a microphone open.
I'll take care of it.
Yeah. If you focus on the patient, you redesign the trial. And I push all the investigators to be more and more on the patient side. It makes no sense to design trial without thinking about patient. We have not only to have the mice models online. It's very nice to do the early development with the mice, but after that, and the only way is to have many patients in your clinic, because the patient teach you everything and you have to listen to them. And actually, it's because of our patient that we are so good at the MUHC. Our patient was advocated for clinical trials and they fight to have the best treatment. So no one's remembered that the MUHC in breast cancer was so good. So we have to continue to provide innovative therapy to our patient. MUHC in few years, 5 years, I told you 2026, will become an indispensable hub for oncology research in years, and all upcoming publication and guidelines will cite the MUHC. So the percentage of patients including clinical trials is an indicator of the highest quality of care. If you go in everywhere, they will ask you, oh, your cancer center is not good. You have only 3% of patients in clinical trials. But if you can be at 20%, you start to be on the top lead. And it's very important, again, for our patient to have the innovative medicine. I will stop here because I wanted to do short and to discuss a lot question because it's a difficult topic. And that's why I prefer the interactive discussion.
Fantastic. Thank you so much, Jamil, Dr. Asselah, for this wonderful presentation, and congratulations on all the work that you've done advancing this very, very important field. Are there any questions in the chat? Nathaniel, if you want to join us as well. So, thank you. So just in terms of getting to the sort of some of the basics there. So in terms of we're all at the MUHC and working with some of these patients, what's the access? How does this work to bring patients into this?
They just have to have a reference from the oncologist. So we asked, we want to inform the patient. So we have different networks, Société du Cancer du Sein, and many other networks to inform the patient. Oh, if you have triple-negative breast cancer, if you have the diagnosis, please discuss with your oncologist about clinical trial. Please tell them that clinical trials ongoing in Canada. So we don't want to say to the patient to come directly to us, but we just inform the patient to discuss with the oncologist. And usually the oncologist, our network is very open, so they send us the patient, but it's very difficult for the patient to come alone. I have breast cancer, I will come. They have to have a way to navigate. I don't know, Nathaniel, if you want to add something on this trajectory.
Yeah, so what's interesting is that, especially in breast cancer, patients speak to each other. There's a lot of forums, a lot of groups, a lot of support groups. So they all know where the studies are, and they all gravitate where the lead institution is. Now, the good news is, with the help of Dr. Asselah, what was done is that the SIM actually treats patients. So they actually give the treatment at the SIM. So this gives us a net zero in our workload, because as you could imagine, everybody is overwhelmed and the system is overwhelmed. So clinical trials are kind of protected, and they get through private money and from the trial money, the nurses to infuse, etc. And patients also referred back to their site once the trial is finished. So these patients don't linger in. So that's quite important because that have allowed us to increase the amount of patients we take in, become a leader in Quebec without, removing care to our other patients.
And so do you have a relationship with many, cancer centers in Quebec in terms of like direct referral from all over the province? Is that how you see yourself eventually to, be that center?
So the big advantage, and Jamil can speak a little more about this, but the majority of active medical oncologists that are in Quebec were trained at McGill. So in fact, myself and Jamil probably have trained over 65% or 70% of the medical oncologists that are all in the regions. So we all know each other. We have a WhatsApp group for all Quebec oncologists. So we know in real time what's available, what's not available. We discuss complex cases. Jamil leads an educational session 4 times a year for all community oncologists to put them up to date on the new treatments and on the new trials. So there's a lot of endeavors and initiatives that have been made to make sure everybody's informed. And I'm sure Jamil can add more to this, but it's pretty easy given that we're a small community.
Yeah, and the fact that also we have the Macpid-Serrois group, all the cancer center, all the hospital sign an agreement, to focus on clinical trials in breast cancer. We have this network that is very helpful also.
That's terrific. And in terms of having, just as an example, I guess, to everyone, in terms of having sort of other subspecialists involved, obviously, in cardiology, we've been involved in breast cancer, obviously in the doxorubicin. Do you feel that you have support from all your sort of subspecialists across the MUHC? Because this is your opportunity if you don't, because you have on this Zoom people from multiple different subspecialties at the MUHC. Do you feel that you have the support of all the specialties at the MUHC that you would like to have? Or do you feel that there's work to be done there?
No, we feel very lucky to have our colleagues supporting, taking care of our patients. But we will be very happy to welcome more students, medical students, residents, to teach them about oncology, to show them the clinical trials and everything, of course. And this, we know many of our colleagues, so we work in daily basis with them, and it's very good to get the MUHC and that McGill network because it's great.
Fantastic.
Also, the big advantage of doing phase 3 trials and phase 2 trials is that these drugs get approved and become common drugs for everyday patients that are not part of the clinical trial program. And clinical trials are very, very, very obsessive on monitoring every aspect of the patient. So, for example, some of these drugs that Jamil has spoken about may have corneal changes. So these patients will go see ophthalmology. So not only do oncologists get exposed to novel drugs that become common practice, but also the allied and the other specialties get accustomed to these patients and the complications. So, for example, the ophthalmology program gets a good, breadth of our patients. Dermatology, for example. So, and for sure, endocrinology, and we now have endocrinology in the cancer center, given that it's such a common occurrence with those new drugs. So this gives an opportunity to everybody to be really at the latest avant-garde, in treatment of patients with complex issues.
Fantastic. I have a question here sent to me about cost. Do you have any issues? What is the cost of these treatments, and do you have any issues to obtain the costs? To have these
the cost is when you do a trial is covering by the pharma, so we do budget, and after that we agree, and depends of the ophthalmology, of the chemotherapy nurse, of everybody. So usually it's good with pharma and with our academic group, other groups, but no, we don't have so many issues. I don't know, in Nathaniel, if you need, you have something in mind.
Yeah, while they're on trial and while they're on expanded access or compassionate access, it's free. Once they're approved by the ministry and go in the list of établissement, well, every drug has a cost. Oncology drugs sometimes can have quite high cost, and that's why the time to get a drug approved is probably the worst in Canada, if we compare ourselves to other provinces. given that the cost can be quite high. But like any other, specialty in medicine, they look at QALYs and they look at, other parameters in order to decide if they approve a drug or not.
Okay. In terms of quite high, do you have any numbers? Are we talking about 6 figures here, or what are we talking about?
So if you look at an antibody-drug conjugate, we're talking about anywhere between 10 to 20,000 per infusion. These infusions are every 3 weeks. So if a patient takes it for a year, we're talking about 19 treatments at 20 treatments. So 20 times 20 at worst, we're talking about a little less than $500,000. Now, if this cures a patient, and Jamil has shown some drugs that have improved cure rates, then $500,000 is nothing compared to having a stage 4 patient that goes on multiple lines of treatment. Whereas other drugs that have the same price tag, for example, Perjeta for breast cancer, early breast cancer, have not been approved by the province. So even though they're approved in the US or other places, they have not been approved, given that the benefit was only 1 or 2% of cure rate. So that was not high enough for the price tag. So usually once they get approved, that there's a real advantage to the population.
And fantastic. That's wonderful. I'm not seeing any other questions in the chat. Are there people who would like to open their microphones to make any comments or ask any other questions? Any other comments, Nathaniel or Jamil, that you'd like to see, things change or things evolve in any kind of way?
No, if we can focus more and more on trials, it would be good, because many people ask us to do more research, basic research, and less clinical trials, phase 2, phase 3. But I think phase 2, phase 3 are very, very important. And what we show, to be like a lead institution is very good, and everybody start to want to, all the Canadian group and in the world also, they want to collaborate with us. They ask us, oh, how did you become the leader? They want to know how we work in daily practice. It's crazy, in our center to be a so small group and a big institution in New York, in London, in Paris. They want to learn from us. It's nice to see that.
There's a little comment here about the ability to do clinical trials and to have a high number of participants. I guess it's more of a comment than a question, but I guess the comment is it seems easier in oncology to recruit patients for clinical trials than other specialties. Is that your sense? It seems that people coming into oncology, have an easier time. Is that kind of the sense that you get?
I just do medonc, so I don't do others, so I can't compare. But no, I don't think it's easy. I think the cancer, the world cancer is taboo. So people thought cancer is you will die. So they are looking for dream, they are looking for hope. So they are coming to us to ask for second, third, fourth opinion, and they are willing to go and study. But I don't know the answer to this comment.
Well, if we look at other centers that have clinical trial programs in Quebec, their numbers, and we're privy to the numbers because we're part of consortiums, a lot of centers don't do even close to what we do. We're sometimes 20 times bigger or even 30 times bigger than other centers with the same population. So I think part of it is culture. So patients, changing the culture of patients, understanding what trials are. The second is also having a team that is able to ease and give patients an ability to get treatments faster, get some kind of advantage to the patient. And, we've been working on that very, very hard. And definitely breast cancer is one of those subtypes where the patients are big advocates. So you'll hear on the news, you'll hear, clippings in the newspaper on patients going on trials, given that they're big advocates for their own disease.
Yes, absolutely. David Rosenblatt is saying Miguel is a world leader in cancer genetics and BRCA. David, do you want to just unmute yourself and just make your comment? Are you, David, you're able to?
I am there. I don't see you, but I was just making the comment that Will Foulkes and his program is one of the best known in the world. And there's large cohorts of patients who are at risk for BRCA1 mutations who often develop triple negative cancers. So I'm sure there's a feed in through that route as well.
Ingrid, thank you very much, David. Ingrid, you have a comment as well. Do you want to unmute yourself? I'm curious, Ingrid, because you take care of also other kind of cancers. You're making a comment about the advocacy in the breast cancer group. Is it different than the other types of cancers?
Can you hear me?
Yeah, yes, we can hear you.
So I think partly it's also the natural history of the disease. I mean, breast cancer patients, even if they have metastatic disease, can live a very long time. So they have the time to advocate for themselves, as opposed to something with a shorter natural history, like, say, lung cancer, where the patients are maybe not clinically well enough. I think that partly makes a difference. And just a little correction, I'm still attending rounds, but I just teach, no longer have a clinical practice.
Okay, fair enough. Thank you. I think, there's a lot to learn from cancer and for your group. Speaking as someone who does heart failure, it's harder to get to get people into clinical trials. It doesn't perhaps have the same brand recognition as cancer does, and probably not the same advocacy as breast cancer groups have. And I think that we can learn a lot from the experience that you have in cancer and in breast cancer about how patient advocates can help advance research. So, I commend you on all that. I think it's terrific. And it's really wonderful to see the progress that you've done, and to see that McGill is really at the forefront of this research. I learned a lot today from listening to this. So really congratulations to you and to all of you, the team in oncology, and Jamil for pushing this forward. Are there any comments or any other questions? Okay, if not, we'll end the rounds there. Thank you so much. Really terrific presentation. Congratulations on all the work that you were doing, and keep it up. Very important very important, to advance this. So thanks everyone for joining us. I wish everyone a wonderful afternoon, and thanks for being here, Jamil and Nathaniel, today.
Thank you.
Bye. Thanks. Bye-bye.